Welcome. This is A Healthy Pace, the heart as it ages. I would ask you, just before we begin this session, because we're using wireless mics and your electronics interfere with the use of wireless microphones, if you could shut off your Blackberries, your various other similar items that are not Blackberries, but still do what a Blackberry does. Please turn those off, too. Don't think that because you carry a Samsung, you're not in there and counted. iPods, no. We can even take off on a plane with the iPod. Nothing would happen. It's okay. But I would hope that you'd want to hear what we're going to say. I'm Ray Suarez from the NewsHour on PBS. And during an average lifetime, your heart will beat about 2.5 billion times. That's about 35 million times a year, 100,000 times a day, more or less. Of course, you might correct that number upward if you've noted an elevated heart rate as you run back and forth between sessions here at about 8,000 feet. The healthy pace, the heart as it ages. You know, the fastest growing group in America is unelegantly called by demographers the old. I'm hoping that as there are more of them, they'll come up with another term, but the old refers to people over 80. And the pace of increase in the population, over 70, 80, 90, and even 100, will pick up steam as this century progresses. And if nothing changes, that would also mean a stunning number of new arrhythmias, cases of arteriosclerosis, aneurysms. Does it have to be that way? Or can we combine lifestyle changes with new medical breakthroughs to extend the healthy life of aging hearts and thus add quality of life to mere longevity? I will introduce my three guests in sequence. They'll make their presentations, giving us the scope of the challenge, what new research is telling us, and where discoveries are leading us in the science of the aging heart. We're joined first by Dr. Mehmet Oz, Professor of Surgery at Columbia University and Director of the Cardiovascular Institute and Complementary Medicine Program at New York Presbyterian Hospital. He'll talk about what we know about the aging heart, among other things, and what new research and new surgical techniques are helping us learn about healthier aging of that vital muscle. Dr. Oz.
So Ray asked me to first provide a broad summary of aging in general. And I'll do this survey very quickly. It is interesting that the heart is ultimately the organ we end up paying the most attention to because it's the one that's always on call. And so although other organs will often suffer from vagaries of function, the heart dysfunction becomes one of the ones we notice the most. It's the reason that, of course, most humans die because it's so essential to our well-being. And like most organs, there's about a 10% decline per decade in function of the heart. And your peak function is around 20. But before I go too far down the path of talking about the heart, let me take a step back and talk about overall body aging. And I had the opportunity to interview a gentleman recently who was an ultra-marathoner. And he had studied these Tarahumara Indians in Mexico that run 60, 70 miles a week when they're 60 years old. And we were sort of curious about how they do this. And he went through and ran a series of analyses. And his conclusion was that your peak endurance for long-term physical activity was age 27. And but the difference in your peak endurance from ages 17 to 27, which is substantial, is paralleled by the reduction in endurance between the ages of 27 and 60. So I'll say it again. Your peak at 27, if you look at where you were when you're 17 and compare it to 27, that difference is the same difference between when you're 27 and when you're 60. Now, that's counterintuitive because most of us think of physical fitness in terms of vertical leap and how fast we can run and professional sports, of course, where you really have to go at 100% of what the human body is capable of doing. But when we're talking about long-term endurance, we actually don't lose that endurance much as we age. In fact, our ancestors hunted animals not by jumping after them and catching them from behind, because none of us in this room are catching a gazelle from behind. But if you run after a gazelle for 2 hours or 3 hours, you'll kill it. Because most animals have to excrete heat from their mouth and they have to breathe through their mouth. So ultimately they have to do one or the other. And so our ancestors would would do endurance hunting, where they would chase after a prey for several hours. So all of our ancestors were equipped to do this for their entire life expectancy. It's interesting because when you look at the decline in function, and I'll cover very quickly some of these, and take muscle as an example, you see a slow decrement over time of muscle mass. And in the heart in particular, you lose muscle cells, about 35% of them, by the time you're age 80. And we don't really know why those cells die. Some of them are programmed to die, a process called apoptosis that I won't get into. Some of them we think might die because the capillaries aren't as resilient, they don't get the blood where they need to be, and the cells die. But the ones that survive get larger as we get older. So we have compensatory mechanisms. The same can be said, for example, for the mix between fat and muscle in our body. And as we grow older, the propensity for us to replace muscle with fat increases. That's visible externally. The one exception, by the way, is the fat beneath your skin, which tends to sink away, literally, as it sags, or be eroded away and be replaced by vacuums, which is why our skin is not quite so taut as we get older. But aside from the cosmetic effects, of course, those are fairly marginal. The big issue we lose as we get older is agility. It's that the lack of balance, the inability to do the kinds of more strenuous physical activities, not because we don't have the muscle mass to do it, but we lose a lot of the coordination, the proprioception of telling where our hands are and our arms are in space as we make motions forward. We have similar declines in intestinal function. We retain less water, by the way, so our ability to hold on to waterborne vitamins decreases. But we make less saliva, which is why our mouths get dry, which predisposes us to dental issues as well as gingivitis. We have less acid production in our stomach, which is a big issue for drug absorption as we get older. But because of that, by the way, our absorptive processes throughout our intestinal system and the rate of peristalsis decreases. By the way, we worry about dementia. Alzheimer's, as you know, which has several probably pathways of getting there, is a problem with neuronal function in the brain. But people with Alzheimer's always have constipation because the same process that's affecting the neurons of the brain affects the neurons of the gut. And so we can see parallels that occur that hinder our ability to thrive in life. And of course, when you don't have saliva in your mouth and GI function deteriorates, you don't taste the food either. And so we have nutritional issues that present themselves from there. I won't spend much time on hormones, although it's clear to most that, again, we have about a 10% per decade reduction in all the major hormones with some fairly abrupt decreases in, for example, women as they go through menopause. But some of the biggest changes that occur hormonally with us occur as we put on fat. Because males, for example, will make testosterone as long as testicular size is normal. So, again, testicles are 3 fingers by 2 fingers wide. And the Aztec word avocado means testicle because they're in pairs and one's lower than the other. So the self-exam is pretty straightforward. If your testicles are normal size, you're making testosterone. But unfortunately, most men begin to accumulate belly fat. That fat becomes biologically active and it converts testosterone to estrogen. So you actually become feminized as you put on belly fat. And that actually causes much more of a change in our hormonal base than our aging would normally predict. And finally, senses across the board, of course, deteriorate. But again, about that same percentage of 10% per decade. So these are amounts that our species can cope with. And the bigger issues that I get concerned about as we age is things like inability to absorb vitamin D, which happens as we get older. And without vitamin D, of course, which is one of our most important hormones regulating biological function, you lose the hormonal benefits, not only bone density loss, but you also lose immune function, and you need vitamin D also for adequate cardiac function, which is our topic. So speaking of the heart, let's shift to that. A couple of big things that happen to the heart. Interestingly, the ability of the heart to squeeze blood out doesn't change much as we go into our 8th decade. But there is the elasticity of the heart, the ability of the heart to relax, to let blood come into it, does deteriorate. And that's called diastolic dysfunction. It's a word some of you may have heard. But as opposed to how well the heart pushes blood out, if it doesn't let the blood in, it can't push the blood out. So it makes the stiffness of the heart that we see as people grow older more of a problem. Part of that is because we lose those muscle cells that I mentioned, about 35% of them as we grow older. But part of it is because biochemically, we don't allow the myocytes to squeeze as readily. And that's, we think, related to how calcium gets in the cells and functions that really aren't well worked out. And we'll be speaking about a little bit today. I wanted to take one leap from there, though, as a heart surgeon, and mention that a lot of the problems we face in medicine occur because we have an older patient with a fixable heart problem. And we have a couple of solutions. For example, aortic valve disease, which I'll show you a picture of now. I only have 3 images, so you don't have to, there's no quiz. There we are. That's what a stenotic aortic valve looks like on the right panel. The left panel shows a normal aortic valve. We think some of this, by the way, is from vitamin D abnormalities in older Americans. Because if you don't have adequate vitamin D levels, then you no longer can take calcium and put it where it's supposed to be, which is the bone. And instead, the calcium tends to go into locations like the aortic valve where they don't belong. The aortic valve is a turbulent area. The heart does beat millions of times in your lifetime. And because of that, over time, a lot of folks don't recognize that this valve will begin to accumulate calcium. And now you've got an 85-year-old patient who's got a very fixable problem with the blood getting out of the heart, but you don't know how to fix it. And we have a very good operation for this with a mortality rate that's about 1%, but the morbidity is prohibitively high for most patients. So mom comes into the office with a couple children, and they say, listen, she's 85. We don't know how long she's going to live, although she's completely with it, lives by herself. Is it really worth spending a year of her life recovering from an operation? Because, again, most everyone survives it, but they don't go back to the same zip code. They go off to a facility where they are rehabbed for a long time. So we have worked on technologies, and this is an example of one. This is a transcatheter device. I just show the simplicity of this because this is just a first-generation device. And the valve is on the left. You see it's compressible. You put it through the groin. So you don't open the chest. You don't stop the heart. You don't go in a heart-lung machine. Use a flexible catheter on the bottom right. You see what they look like to push it up to the heart. And we literally use a crimper, a very simple device, to take that circular valve and squeeze it down to smaller than the size of a ballpoint pen. And when we do that, this is what you see. Again, a very simple animation demonstrating a catheter going from the groin up into the heart. Patient's awake. Catheter goes across the arch of the aorta and across the aortic valve. We have historically put a balloon across. That's the aortic valve that's stuck in the middle there. And you take a balloon, you blow up the valve, which is called valvuloplasty. It works, but only for a few months, which is why it has not become a mainstay therapy. But here's the catch. You now put that same balloon across after you've opened the valve with the stent, and you blow open the stent within the aortic valve. And when you do that, you now have a valve that's been inserted without surgery. And the cool thing about this is two things. Number one, we think we only take care of about half the patients in America with aortic stenosis, which is the most common valvular abnormality. This gives us the opportunity to help a lot of these people if they desire it. It does another thing, though, that's very important. You take all the risk of surgery and you compress it into a very finite time, 5 minutes, when you put the device in. It takes about 20 seconds to put this in, by the way. So right around that period is when you're going to have a stroke if you're going to have it. So most people, when they're 85, would say, listen, you know what? If I'm going to take a risk because I can't breathe anymore, make it a 5-minute risk. And if I pass, I'm okay. And if I'm not, then it's done. But at least I get my thing done, my chances all taken at once. I roll the dice and I take my odds. And that's why I think technologies of this nature, and there's similar devices that are being made for other valves as well, offer us the opportunity to help an older person's heart, even though, which is, again, a strong structure, even when the rest of the body is weak.
How long does it last?
So these devices in models that are used with, in humans, they've only been in place for about 2 or 3 years. So far, excellent results. But we usually plan for 10-year results with valvular disease, and we think these will last probably 7-8 years. But we don't know. And I think a lot of it will depend on calcium metabolism. What we have started to do in all of our patients, by the way, any of you who have valvular problems or have prosthetic valves in you, I would strongly urge you to start taking vitamin D. Because we think that a lot of what will allow these valves to last a longer period of time will slow down ectopic deposition of calcium, which is ultimately why these types of devices fail. I would never put this in a young, healthy person. This is to be used in people who we think are prohibitively high surgical risks.
High risk, yeah.
Thank you, Dr. Oz. Next, Dr. Elizabeth Nabel. She's director of the National Heart, Lung, and Blood Institute, where she oversees an enormous research portfolio. She has extensive experience in biomedical research, clinical medicine, and policy making. And I guess if I had to sum up what she has to say today, I guess it's simply the situation is not hopeless. In fact, there's plenty of encouraging news about what we can do to maintain a healthy heart as we age and even undo or reverse some of the effects of aging. Dr. Nabel?
Good. Well, thank you very much, Ray. Whenever I come to Aspen, I always get jazzed because this is such a healthy community, and there are so many wonderful athletic things to do that I thought that I would focus my comments on what many of you in the room might be thinking. How can I preserve or improve my heart function as I get older, and is there any relationship to exercise? So that's what I thought I would focus my comments on. Dr. Oz has already started to tell you about what happens to the heart when we age. We know that we do lose some of the heart cells. We know that the remaining cells get a little bit bigger. And in addition, the heart compensates for the loss of those cells by producing scar tissue, what's called fibrosis. And that causes the heart, in turn, also to become a little bit stiffer. The same process happens in our blood vessels as well. So particularly in the aorta, which is the main pipe that exits the heart, and the blood vessels that go up to the brain and to the arms, and the aorta that goes down through the abdomen to the lower extremities. The wall of that blood vessel over time also loses some of the muscle cells. And as muscle cells start to die, they secrete proteins that then produce the scarring tissue or the fibrosis. So we know there's replacement of muscle by a little bit of scar tissue. And you can imagine that scar tissue doesn't function like a muscle. The scar tissue becomes kind of like a stiff pipe. It loses the ability to contract or relax. And so as part of the normal aging process, then our blood vessels, our pipes get a little bit stiffer, and our heart gets a little bit stiffer. So that's sort of the normal aging process. And we also have a fairly good idea about some of the biological molecules that account for that. One of the molecules that's very involved is a growth factor that we abbreviate and we call TGF-beta. It's called transforming growth factor beta, but it's one of those molecules that leads to the scarring process. So one of the questions that we want to ask, is this aging process, this the scarring process, inevitable? I mean, is it something that we're all going to go through? Or is there something that we can do about it? As Dr. Oz said, due to other changes in our body, as we age, we often reduce the amount of physical activity we engage in. Our joints get a little bit stiffer. We lose a little bit of muscle mass. We put on more fat. We're just less inclined to engage in physical activity. So is the process that occurs in the heart and the blood vessel a natural consequence of aging, or is it a result of physical activity, or a little bit of both? Well, there's been some very interesting studies done recently that has shed some light on that, and I thought I would tell two very brief stories about that. The first is a story about the heart and the effects of exercise on the heart. So a group of investigators took 3 groups of individuals. They took a young group of individuals who were healthy but pretty sedentary. They took an older group of individuals whose average age was about 69, and these were individuals who were otherwise healthy but sedentary. And then they took a group of individuals whose average age was 69 who had engaged in masters athletics. So masters level athletics, for those of you who may not be aware, are, I think the age is either 40 or 50. I don't, maybe someone knows.
50.
It's 50, yeah. Individuals who engage in athletic competition after age 50. And it's multiple types of competition, running, track and field, or one of the forms of it. And there are masters competitions and medals and records and all this sort of thing. So they took a group of individuals who had engaged in masters endurance competition sports, average age 69. And they did a whole series of heart function studies to try to understand what their function was like. And what they found that was really quite interesting is that the masters athletics at age 69, their hearts performed more like the young sedentary person at age 20 than the old sedentary person at age 69. So in other words, the person who had engaged in master level competition, and these are folks who, it was pretty high level. They had on average been doing this for, about 10 years, and they were on average of doing around 10, 15, 20 miles a week. But nonetheless, if you looked at the parameters of their heart function, the filling capacity, you talked about the filling capacity, the diastolic dysfunction, that improved. Stroke volume remained the same. And the compliance of the heart was greatly improved. So their heart didn't function with as much stiffness, which was really quite interesting. So their heart picture then was much more like the younger person. The other story that I will tell is the blood vessel story. So I mentioned to you that the blood vessel pipes get a little scarred or fibrotic as we age. And there's actually a genetic disease that mimics that to a certain way, and it's called Marfan syndrome. It's where you have a genetic deficiency of a fibrous tissue called elastin. And your pipes don't necessarily get scarred or stiff, but you get bulging aneurysms. Due to some very interesting work by an investigator researcher by the name of Dr. Dietz, who's at Johns Hopkins, he's found that a blood pressure medication works very effectively in animal models of this genetic disease, not by treating the blood pressure side of things, but by inhibiting that growth factor that I told you about earlier, the TGF-beta factor. And by modulating the TGF-beta factor, this particular blood pressure medication, which is called losartan, can actually retard, slow down, and actually reverse the aneurysm formation that occurs within these individuals with Marfan syndrome. So the research hasn't been done yet, but the next logical step is to think about some of the blood pressure lowering medications may have effects not just on blood pressure per se, but also might have effects on how the stiffness of our pipes as we age. And that will be research that my institute will want to begin to fund and look at. So I think the message that I want to leave you with is for those of you who wonder what the benefits of exercise might be other than it makes you feel good and you do stay healthy, there actually may be beneficial effects on the heart and potentially the blood vessel to retard or slow down the stiffening process that occurs as we age.
Thank you, Dr. Nabel. Finally, we're joined by Dr. Victor Chow, Chancellor of Health Affairs at Duke University and President and CEO of the Duke University Health System. He's got exciting news on stem cells, regeneration, and aging.
So I'm a cardiologist, and like Betsy and Mehmet, I do cardiovascular research. In fact, a fair amount of research is oriented towards molecular genetic research. And so as I think about this discussion, heart disease is kind of layman's term, but what you really heard is that the primary disease is one of coronary artery disease. That in fact the heart muscle does fairly well until you reach a late stage. So Ray says 2.5 billion beats in the lifetime of 78. Actually, I got 3 billion. Maybe my heart rate goes a little faster than yours. But that's about 1 million barrels of blood that can fill 3 supertankers. And that's how much the heart. Imagine you have an organ that keeps pumping for 70-odd years. I mean, I don't have a car that doesn't need a replacement of a part or whatever. So that just simply says the heart is actually very durable. Now, what's amazing is when I was in medical school, and it's still taught in medical school, the heart doesn't have a capacity to regenerate. It says that this is a dogma, that in fact we're born with a number of cells, and that's the number of cells we're going to live with. And if Mehmet's numbers are right, so that by the time you live to 70-something, you start losing that many, well, you'd think that you'll lose a lot more, right? So I think that's the amazing information. So I think the real interesting information is that the dogma that heart cells cannot divide was based on some very old experiments and technology where you can take heart cells, put it in a culture dish, and try to drive it to divide, and it doesn't do it. It says it's terminally differentiated, or post-mitotic, as they call it. And you can also look at under a microscope and try to count cells, and you don't see a lot, cells turnover when you use conventional techniques. So if one considers all that, there's something that doesn't quite add up. And I think what's exciting about this, of course, is the research has been done the last 10 years or so, particularly the last 5 years. A number of investigators begin to say, well, maybe we ought to relook at this dogma and use somewhat different techniques. And now I can tell you that the information based on animal studies, and I'll cite a couple of human studies, show that, in fact, the heart can regenerate. And perhaps that explains why it's so durable, at least reasonably durable, until you have coronary artery disease, you have hypertension, you have other things that put a big load on the heart. Then the fibrosis and the loss of muscle can accelerate. So Pierre Anversa is one of, I think, a pioneer in this area. He is now in Boston. He was in New York. And he began to look at this whole dogma by looking at animal studies, using somewhat different technique, and particularly creating a heart attack infarct by ligating the coronary artery. And using more contemporary techniques, he can actually see the evidence for cell division. And when he further looked into the situation in this very, I guess, extreme situation when you have big injury, he actually can see the presence of these small cells, which are probably stem cells. And so the work goes on to suggest that, in fact, the heart can regenerate itself, and that, in fact, there may be related to either the cells themselves going back into a cell cycle under some extreme stress, or that, in fact, stem cells begin to play a role. Now, there's been some debate where these stem cells come from. A group of individuals initially said they seem to come from bone marrow, and there's probably some truth to it. But I think the prevailing data would suggest that the heart itself has resident stem cells. These stem cells in 3 different groups have defined them by different markers: c-KIT positive, SCAR positive, and islet cell. They're all slightly different. It could be that because we're looking at those cells at different conditions, different time, etc. But these cells' ability to generate not only heart muscles, but also smooth muscle and endothelial cells, and seem to play a role in the post-injury repair and regeneration. But I think the real interesting story is actually the fact that these cells are probably doing regeneration continuously. And in Anversa's study in animals, he suggests a pretty rapid turnover, which is a little bit difficult to understand. But I think the most exciting study is a study published in Science from the Karolinska Institute this year. They did some really smart things. They figure, how do we date these cells and date the DNA? So in the 1955, we had a lot of radioactive C-14 atomic bomb testing. So he decided, I'm going to take autopsy specimens from people who die, and carefully analyze them, but take them before 1955 and after 1955 birth. And then take the DNA out, because if the C-14 is in the atmosphere, it becomes carbon dioxide taken up by plants, and then you eat it, it gets into your body, and then it gets incorporated into your DNA. So you can take the nuclei from these cells and actually carbon date them. The long and short of it is that if you were born before 1955, you still see a peak of carbon-14 cells, suggesting that after your birth and somewhat further along the line, you are regenerating, in fact, your heart cells. And if you're born after 1955, you find more, of course, this C-14 in younger cells. And the estimate, I will read his data, says that about 1%, if you're age 25, there's about 1% turnover per year. But if you're age 71, it's about 0.45%. So you lose the ability to repair yourself, regenerate over time. That if you over 70 years, about half your cells would have turnover, and therefore most likely replaced, maybe not fully replaced, but certainly greatly replaced. So this is really, I think, almost definitive data that the heart can regenerate. So let's pull the 2 pieces together. You have a heart attack, you can do some regeneration, but people with big heart attacks end up with heart failure. So consequently, it's not enough. But over the wear and tear, you can regenerate your myocardium sufficiently. Well, what's happened is recently the data shows that if you look at these stem cells, the stem cells from older people have a shorter lifetime than the stem cell from a younger person. And this leads to something that Mehmet talked about yesterday, which is a telomere. That in aging, in fact, at the end of your chromosome, you have these lariat-like DNA repeats, which are called the telomeres. And they try to cap your chromosome to protect them when your cell divide from catastrophic fusion, etc. Over time, every time the cell divides, you lose a little bit of this telomere, so that at some point when it gets too short, the cell can't divide and it goes into cell death. And there's an enzyme called telomerase, which tries to repair this and create more of the telomeres. And that research now shows that if you have chronic injury, the stem cells telomere and telomerase activity goes down, and if you're aging, it goes down as well. Now let me talk quickly about blood vessels. The issue about blood vessel is that the inner lining of a blood vessel is a layer called the endothelium. That layer is the protective layer. It interfaces between the blood and the pressure and the blood vessel. It's a very fine lining, but it's able to prevent inflammation, thrombosis, cholesterol deposition, you name it. And so, but over time, when you have aging and risk factor, that endothelial cell begin to perform poorly, called dysfunction. And therefore, it enhances the stiffening and the atherosclerosis that you see with age. Again, it turns out this cell dies. We used to think that it just stay there and dysfunctional. And we used to think that when it dies, the adjacent cells move into the area to cover it, called regeneration. Well, that's probably not the case. We have in circulation stem cells called endothelial progenitor cells. They are progenitor cells that come from bone marrow, that comes into circulation, and they go to area where you lose endothelial cells, and they help them repair. Once again, when you have cholesterol, hypertension, diabetes, these cells don't do quite as well, and aging shows that these cells actually lose and actually exhaust the total reservoir. Pascal Goldschmidt, when he was at Duke, did a really interesting study. He took animals and subject them to atherosclerosis. These are genetic animals, ApoE knockout. And so these animals develop atherosclerosis. And then he said, young animals, old animals. If I took the bone marrow and actually transplant it or take those cells out, actually the young animals can prevent old animals' disease, and the old animals' bone marrow actually cannot prevent young animal when they have disease. So this goes to show that stem cells have limited capacity, and therefore, over age and over risk factors, etc., you actually lose them. So my final take-home message, treatment. I think the things that Mehmet and Betsy talk about, blood pressure, cholesterol, diabetes, antioxidants, they all try to prevent cell death, but also at the same time improve endothelial function or maybe cardiac cell function. And some evidence they actually improve the stem cell actions as well. Because the future, therefore, would be finding drugs that can actually give you a fountain of youth, which is that stem cells maintain their youthfulness, being able to regenerate as you need it and repair as you need it in a blood vessel. And, of course, in addition to all these lifestyle and other things, there may be a drug. And maybe, Robert, you find them in your company in terms of what those drugs are, being able to enhance longevity from the aging viewpoint for the heart. Thank you.
I hope it hurries up.
After you've all listened to each other's opening presentations, did you have any questions of each other? Or did everything everybody said sort of say, ring true?
I was going to ask Victor, just to follow up on Pascal Goldschmidt's experiment about old bone marrow versus young bone marrow. Yeah. In lieu of that data, are you optimistic that we're going to be able to create mechanisms for stimulating bone marrow in older patients? So let's say you have a heart attack, we do what we can to save whatever muscle's there, but we actually can stimulate bone marrow stem cells to more rapidly reproduce and hone into the area of injury.
Yeah, actually, I didn't give the data in detail. Actually, when they look into the bone marrow, the population of endothelial progenitor cells markedly shrank with age. Whereas the other stem cells still, the red blood cells probably reduce as well, and the white cell progenitor. But apparently there's an exhaustion, if you will, of this. I guess the question is, why do they happen, right? I mean, I think some of the things that you and Betsy talk about is probably some of the underlying mechanism for, in fact, maybe the excessive use of these cells to repair exhaustion of the pool and inability to regenerate the pool. Betsy, any ideas?
No, but I think another comment might be, Victor, I believe that there has been some work looking at the effect of exercise on stem cell populations,
yes,
and showing a beneficial effect, particularly on bone marrow mobilization.
Right. In fact, statins, the losartan, the blood pressure lowering drugs, antioxidants, they've all shown to, if you measure these endothelial progenitor cells in circulation, they're all shown to have mobilize and increase the number. But most of these studies are short-term, so you can see kind of an acute increase.
This new information about the regeneration ability of cells in the heart comes on the heels of new information and new research about more plasticity in the brain than we had assumed was the case in earlier years. And I'm wondering if we've gotten down to the point where we understand programmed cell death better, so we know why cells shut off when they do, and whether that's a mechanism that's reversible or neutralizable.
I would offer that we probably don't know as much as we should. It's interesting when you think about why is it that we know more about stem cells now as opposed to 10 or 20 years ago. It's in large part because the technology has improved. Our ability to image cells, our ability to understand how cells function at a very basic molecular level, our understanding of the genetics of how cells grow and divide are much better. And because there is so much potential here for future knowledge, it's one of the reasons why this particular area, stem cell research, has become a very important area of research at the NIH, and particularly for the Heart, Lung, and Blood Institute, because of the potential. There's a whole vast number of questions that we need to address. There's a lot of data we need to collect, all with the eye of thinking about potential therapies down the road. And I think one of the fascinating pieces of this is that one of the beauties, I think, of cardiovascular medicine and surgery is our ability to combine cell-based therapies along with device therapies. So what if we could potentially implant endothelial cells on this aortic valve implant that you have that could secrete a substance that would retard or slow the calcification or improve the function of the valve? I think that these are the kinds of therapeutic modalities that we would see the research going towards. I don't know, maybe the two of you can comment.
Just to comment, I think that it's quite right to say that most organs have some regenerative capacity, but they're not all the same. In fact, this study done by the Swedish group, C14, they actually also look at the brain, and they published in Proceedings National Academy of Science. And they found the brain, actually, they were not able to show the kind of turnover that they saw in the heart. So while I think the news is good, I think that, in fact, the capacity in the brain seems to be more limited. Now, with regards to understanding them, if you look at the bone marrow, and people have looked for a long time about what they're known as a niche, which is what supports a stem cell. And there's a lot of work now looking at factors and others that support stem cell growth, proliferation, etc. In the cardiovascular area, we just begin to look at that in the heart and in the blood vessel. In the heart, and particularly, what is the environment by which these stem cells thrive and what do they make? And as Betsy knows, that's part of my research. We've been looking at what do stem cells make and how they create an environment that can enhance repair regeneration. Because one possibility is, you know these factors, you can give these factors rather than giving stem cells. And that is certainly a hope anyway. So that's some of the research possibilities.
If I can just throw two ideas out. Ray, you mentioned in your earlier question to all of us this issue of apoptosis and programmed cell death and how we might be able to retard that. But it's a double-edged sword, because what ultimately drives many of these processes are internal editing systems of the body. So within our cells, we have, for example, a P53 system, which is like a watchdog, looks at the DNA and figures out, is that DNA good enough to be my DNA? And if it says yes, then you make cells from it. If it says no, it turns on apoptotic mechanism, so the cell kills itself, commits suicide. That's sort of a good thing, because if the DNA is not made right, you want it to not progress into a cell, because it could be a cancer line, for example. And so we know that in species, and we also do these through knockout experiments, but none of this data is mine. This is I just read this stuff. But it's sort of cool and interesting stuff to follow. But you realize that you can create models where the animals will never die of old age, but they'll die of cancer very quickly, or vice versa. The animals that will develop cancers very quickly but don't show any signs of aging, because you don't have a very aggressive editing system knocking out cells, depleting populations, let's say in the heart, for example, 35%. So your heart beats wonderfully, but you let a couple pancreas cells get away with it, and they become cancer, which is why I think we sort of have that nice balance when we do things correctly. But let me just progress that to this whole issue of epigenetics, and I'd like to throw this out to each of you. So in the winter of 1942-43, when Europe was in the midst of Second World War, the Nazis embargoed the Netherlands, and they blocked food intake to that country. So during the course of that winter, the average intake or caloric availability was about 800 calories per person, which is barely enough to keep you alive. Eventually, the winter ended. The calorie restrictions were lifted. Those women began to eat. Ultimately, the Allies won the war. These people had lived normal lives. They went back and looked at the kids who were born the following summer. And 20 years later, in the early 60s, those people had a higher incidence of hypertension, and they began to develop many of the chronic illnesses that we associate with the illnesses that we today know are stripping so much of the money out of our healthcare system and the vitality of our citizens. And the concepts have more recently been described. There's a very nice piece in the New England Journal within the last year that although our DNA is our DNA, we have the ability to turn on and turn off certain elements of that DNA depending on how our body projects the future will look. So when you're in your mother's womb, you make estimates. Your DNA does your cells do, of what's going to be out there when you're done. And if you project that there's going to be starvation, you will adopt a thrifty genotype, or rather a thrifty phenotype. You'll express your genes in a way that would predict that there'll be no food out there, which is probably a very smart thing for our species because it allows us to adjust more rapidly to an ice age, for example, because our genome just doesn't adjust quickly enough to be able to adapt to the environment around us. So I'm curious what you both think about the role of epigenetics in all this. And as we embark on a new generation, they were joking about this being the regeneration generation. So the kids that are born in this decade who are exposed to a lot of different foods and environmental influences that we were spared from, even if we weren't born before 55. Are we projecting changes to the way they express their DNA that may ultimately change this natural history?
I think this the area of the intrauterine environment is getting a lot of attention now. And there's a lot of thought that there are probably local milieu exposures in the intrauterine environment, and there may be some epigenetic changes that occur that can influence an individual's susceptibility to diseases long term. And the area where this research is most active is in the area of diabetes. So there's some data to suggest that women who are diabetic or who are obese or have other certain conditions, the susceptibility of their offspring are greatly enhanced. And there's some early evidence to suggest that the same is true for hypertension. But I don't think we understand the basic mechanisms surrounding these local environmental exposures versus the epigenetic changes well. But certainly the observations suggest that we need to do much more work in this area to understand it better.
Yeah.
May I ask Mehmet a question? I think you've been, certainly there's a lot of interest on caloric restriction.
Yes.
And, particularly with people as they age. Is there any data that looks at the cardiovascular system and what the mechanism is?
Yeah, actually, there's 2 bits of data. There's 1 bit human data, very small group of people, and some, the newest primate data was just released recently. Looking, I think they're about 20 years out or 25 years out now on long-term calorie restriction. But by the way, calorie restriction is a reduction of what you would normally take in the rodent models of about 35% of caloric intake. But it seems like even at 15% of reduction of caloric intake, you still get most of the benefits. And the principle behind this movement is that with calorie restriction, you send very clear messages to your DNA that there's starvation out there, so you don't want to bother wasting energy reproducing. Instead, just live longer. And so in rodent models, it's pretty compelling, reflecting increased life expectancies of about 50%. So taking us from, let's say, 80 to 120 more comfortably. That would, in theory, be what we could achieve. So in order to demonstrate whether this is truly useful in larger mammals, there was a series of primate experiments started. And in fact, the survival numbers in the primates is superior in the calorie-restricted population, and the cardiac function remains healthy in those animals. The only human data I'm aware of is a small study that was done. I just became aware of it because we were preparing for a show, where they took individuals who were calorie-restricting voluntarily and showed not only improvement in all the things you'd expect in the biochemistry of the body, where the fluid coursing through the veins looks better. But actually, the cardiac function itself, both in terms of its elasticity, which is the big issue I mentioned earlier, how stiff the heart gets, that seems to reverse actually in some of these calorie restriction folks. But then these are anecdotal. It's not really fair to call it that, but that's effectively what it looks like. These are not randomized trials because you can't subject people to these things. And I can't take this half of the room and cut out a third of your food. And it's also not very practical to do for us. But the same way that Victor was speaking about finding what it is that stem cells give you, and maybe just giving that to you, the hope here would be not that you would calorie restrict, but we'd figure what about calorie restriction turns on sirtuin, which is the mother molecule that causes this. Maybe just skip the calorie restriction part and just turn on the sirtuin.
What does the primate study suggest in terms of practical terms? What was the percent calorie reduction? How long were the primates restricted? And what would that translate into
They actually restricted the primates.
Humans.
They restricted the primates by 30%.
So what?
And over 20 years. It's either 20 or 25. It's a long time.
So that's an
Yeah,
extraordinary.
no, they did the experiment. Now, if you look at the animals, I must say, most of you would probably rather be the non-restricted cat animals. I mean, the restricted ones all look like
How many
Gandhi.
more years you
They're
get?
Gandhi with fur on top.
Yeah,
You know,
yeah,
they
exactly.
don't look very happy.
Gandhi, yes, right.
That's right. And it is not practical. But again, I'm going to focus on the reality. Well, I mean, all this controversy about resveratrol all arose from that because the red wine, if it has a benefit, is 90% of it's from the alcohol, not the fact that it's red wine. And even the red wine benefit, the thing that makes it red, the skin of the grape, is probably not the resveratrol by itself. It's the other phenols that are in the skin that's conveyed together with the red wine to your taste buds, but as well to your genes or to express your phenotypes. But if you take resveratrol, which is one of the elements, and it's been tried in rodents, but at a concentration that's about 140 bottles of wine a day. So as much as you might like wine, you're not going to get there by yourselves. But at those high doses, they get rodent survival numbers that are very similar to calorie restriction. So it is attractive, appealing to think that resveratrol might be useful in humans. We just can't possibly know that yet. So I'm very nervous about, you see all those ads on the internet now. A lot of them have pictures of people and they're all fake. Those companies all are involved in different types of shenanigans. But the fact of the matter is, resveratrol itself is our leading candidate right now to be effective in this area. I'm quite certain we'll have other, even more promising products eventually released. But again, it's a double-edged sword. We might actually find that although we give you longevity, we may hurt you in other ways.
Let me ask Mehmet what you think about the Mediterranean diet. What's fact and fiction about the Mediterranean diet?
Bessie knows this better than I do. It's kind of you asked the question. But at least I'm of Turkish origin, so I grew up with the Mediterranean diet. It's interesting. You look at the life survival curves of folks, and you look at the different things we do, like put you on statin drugs or beta block. I mean, those interventions are absolutely dwarfed, at least when it's been looked at in context of the Mediterranean-style diet by being on a diet of that nature. The catch, however, is you don't just get the Mediterranean-style diet with the Mediterranean-style diet. You get the whole lifestyle. And so it's hard to divorce those issues. So, for example, if you can have a glass or two of wine in the evening, it's not just the wine you get. You get the conversation that goes with it. You get the fact that you have the time to sit down and enjoy it. So it's hard to separate those out. But if you're talking about a study based on humans, it's a pretty smart way to go. And the combination of olive oil, which is not rich in omega-3 fats, it doesn't have the things we keep bragging about. It has a lot of omega-9 fats actually in it, but it has other phenols as well, and other again chemistry experiment products in it that we don't quite know how they function, but they seem to protect us. And again, you take lycopene, which from tomatoes, which is really effective, but much better absorbed if you mix it with oil. Well, you can if you combine tomatoes with oil, you have pasta sauce. So, these are sort of interesting things that people have found appeal to our taste buds. And what I'm really fascinated by, I don't know if anybody in the audience may know this information, but we're finding all kinds of cool things. You mix cinnamon with a certain kind of food, and all of a sudden you potentiate the effect of the nutrients that were in the food to begin with. So there's something sacred about the way our ancestors made foods, which offer us a lot of optimism when we look for long-term cures.
A lot of the conversation so far, and I've been listening very carefully, has been carried on with almost the conceit that all human beings are issued the same standard equipment at birth. Yeah. And with all the stuff that's been going on with sequencing the genome, with understanding genetic structure, are we learning more about genetic predisposition to either heart health or heart trouble in age? And I'm wondering whether we can use that knowledge not to encourage fatalism and passivity, like, oh, well, I'm going to die of a heart attack, might as well live it up, or, in fact, start changing the way people live in their 20s and 30s or their teens with that understanding that genetics aren't necessarily destiny, but if you want to play the averages, you can help yourself a lot if we've located a predisposition.
I think that's an outstanding question, and I can tell you, Ray, that's the question that dominates a lot of our thinking right now in the Heart, Lung, and Blood Institute as we think about research. I think what we're learning from some of the very early genomic studies is that there is a great deal of individual variability. There's some commonalities, but there are individual variabilities. There are individual variabilities. There also are differences among different ethnic groups. But the question is, given your God-given genes and your starting point, what can you do to enhance your health? And I think those are the kinds of questions that we're going to be asking over the next few years as we now use more sophisticated DNA sequencing techniques to get a better understanding of what really constitutes genetic susceptibility, particularly to what we call these complex heart diseases like blood vessel blockages and diabetes and hypertension as well. So to make a long answer short, great question. We don't know yet, but we need to really focus on that question.
So if I
with research.
keep asking, eventually in the future I may get an answer.
Yeah.
Well,
Maybe.
Well, you know, that's just pursue this a little bit.
Maybe.
I'm going to butcher this quote, but my wife Lisa will remember. But I still Adler used to say about actors that, you know, the first half of life you have the face you're born with. The second half is the face you make. And I think the same is true in many ways for our risk factors. By the time you're age 50, probably 2/3 of what's going to determine your health quality are lifestyle-related changes. So the real question becomes, how do you educate yourself to know what to focus on? And the shotgun approach that we've been all advocating is sort of onerous to you, because we're saying do all these 50 things, even though you're probably only susceptible to 5 of them. So I went to a spit party recently. You know what spit parties are?
No.
The modern spit parties.
No, I have no idea what it is.
So you have a little test tube, you spit into it, and they run your study. So there's a couple companies that do this. There's 23andMe, Navigenics. I mean, there's a bunch of Pathway Genomics. There's a bunch of companies that do this now. But what's interesting about what they do is they give you back a report that tells you, here are where your weaknesses are. So in my own personal example, my father is big-time overweight, always has been. He's a physician, knew it all along, has never had an issue with it. He's never became a diabetic. I could never understand all this. So my report came back, there's almost no chance I'll get diabetes in my lifetime, almost no matter what I do. It's probably less than 10% of the average person's chance of getting diabetes, because my ancestors probably had to do the things to your body that people who get diabetes can't afford to do. I have a very high incidence in my family of macular degeneration, which is what the genome also predicts. But I have almost no risk of prostate cancer. So to play it out, if I eat my leafy green vegetables to give me lutein for my eyes, I don't have to have rectal exams. So,
What a trade-off.
I think it's a pretty good deal. But I point this out to everybody because instead of us saying go get a PSA every year, when we know, in fairness, that getting a PSA probably not doing you much of a favor. I won't bore you with the numbers, but you got to test 1,000 people for 10 years to do 150 surgeries to save one life. I mean, it's just the numbers aren't good to use that kind of a broad screening tool. But if I was a high risk for prostate cancer, I'd be getting my PSAs pretty quickly and all the other things that go along with it. So by giving you a little bit more advice about where your weaknesses are and focusing on that, Ray, I think that's how we're going to use the genome to educate us. Because, yes, we all dealt with our cards, but if I can cheat and find out what my cards are, and yours is also, we can play a better game of poker.
So I'm a little more guarded about Navigenics, 23andMe, and the genome.
Fair.
And, I think that resequencing is the way to go. Sequencing. Most of the information is very limited, as you know, from some of the stuff that's
Can you just explain to everybody what your specific concerns are with those companies and other ways you think it might be able to?
Well, I think the companies are looking at markers which are already known out there, and they're genotypic markers. And they look at maybe 18 traits hair color, etc., and a number of genes. It's not an end-all and be-all. So most of the genes are very well known. So therefore, if you don't have it, doesn't mean that you don't have any risk, because there are many other things that we just simply don't know. So there's a long way to go, in my opinion. But I think the real question is what was asked. If we do know, would it change behavior? That's also not known.
Yeah.
Now, I'd like to believe that's the case, but I think we do need to do research to show that information drives behavior. I do know that Jeff Ginsburg at our institution is doing such a study in diabetes. People who have susceptible gene diabetes, not family history, but knowing whether you have a gene or not makes any difference in the behavioral issues. Some of these things I think a behavioral science is going to be a very big part of this, because most of the time the information is what we do with the information is the issue.
Right. Let me just follow up on this, because I'm intrigued by this. I've been looking at this prostate cancer issue recently, so have a lot of other folks. But let's just take that example as Victor, if you could. And prostate's not the heart, but they're connected in some ways. So there are 4 genes, from my understanding, that predict that if you have elevated PSA, you're probably going to have a higher chance of having a kind of prostate cancer that's really a cancer, that goes out and metastasizes and does a lot of bad. And if you don't have one of those 4, you can still have a prostate cancer that metastasizes and causes the end of life, but the odds are more in favor that you're going to live with your prostate cancer till the end of your life. And so, we'll probably figure out a dozen more by the time the year's done, but I've seen 2 papers from large institutions looking at those numbers, one from Europe, one from this country. The question then becomes, at what point do you get more comfortable basing testing advice on gene data?
Right. I think this is why you have to have some outcome studies linked to it in terms of intervention. I think that, for some of the genes which are have, high prevalence in populations that pretty much give you a high probability of disease, like BRCA1 and 2, that's become pretty straightforward. But I think some of the markers that people are using right now, I'm just not sure how useful they are at this very point.
I think it's a matter of certainty and probability. Yes, I think these tests can provide you a basic low-level, sort of first pass kind of information. The information, quite honestly, that they're providing you is nothing more than a search engine of the existing medical literature.
Right.
So let's be realistic. I mean, an individual could probably spend the time and go on the web and get the same information. The question is, there's no doubt that with more research, we're going to have a far greater understanding. We're going to have far more sophisticated knowledge about susceptibility. So at what point do you want to jump into the game? Do you want to jump in early when there's just a minimum of knowledge, or do you want to wait a little bit and jump in later? I think it really comes down to an individual sort of
Let me ask you
decision.
a concrete question. I'm only picking the prostate because we have numbers on it. Ray, I hope you forgive me for this. But so let's make it practical. Let's say a loved male relative of yours who's 55 years of age has a PSA over 5, and it used to be less than 2. But they happen to have gotten one of these tests, and it turns out that they don't have one of these 4 proteins. In fact, they had none of them. Would you let them have a prostatectomy? And let's say they biopsy it, and it's always a Gleason 6. Always. So it's a Gleason 6, which means it's a cancer, but just barely. So what do you do?
I would consult with some expert prostate cancer surgeons.
They won't tell you. There's no answer.
I know there's no answer, but I would get some expert-informed decisions, and I would probably err on the side of a conservative management.
All right. Victor, would you do the same thing?
Yeah.
All right.
How about you?
I wouldn't have my prostate out. Would not have it out. Especially because I know that there's some data that over a year's time with lifestyle change, we seem to actually not just drop PSA levels. This was Dean Ornish's data that I talked a tiny bit about yesterday. But you take the serum from those patients and mix it with tumor cell lines in vitro, and it seems to arrest tumor cell growth. So it's pretty compelling. I mean, it's almost too simplistic. But it does seem to, and I love this because it begins to challenge our conventional approach to giving you advice, which is get all these tests. Maybe the better thing to do is not do that, but focus on what you need to focus on. Yes?
Can I make a comment about the 23?
Stand up, please.
We did it as a family. We actually did it on Thanksgiving.
Okay, before or after food?
Well, you had to do it.
Exactly.
Everybody hated it. But,
Can I just say one thing? So I mistakenly did it with food once, and you end up with animal DNA. So you get this very alarmed bit of feedback, you know. We think you must live on a farm.
I have 3 children in their 20s, and the reason why I did it And
So
I think for
let's.
somebody in their 20s, it's great because they're just starting out.
So what did your children do with the information?
They didn't do anything. They looked at it and they read it. They kept it themselves. And I'm hoping they're in their 20s.
Yeah.
I'm hoping that they learn from it and will use it.
Yeah. This is my point. I think that the information should be used in such a way that one would follow by an intervention and look at whether there are changes behaviorally.
Well, I think if there was something radical that came back, that perhaps there was nothing radical on any of their tests. If there was something, then I think that obviously that they would have done that. But I do think it's a good thing for kids that age especially. That's my opinion.
In the far back.
I'm on the board of 23andMe, so I just wanted to make two observations. One is, I agree with you. We really hope it will change people's behavior, which is what's good. And we're doing a study to figure that out with respective parties. The second is simply a data point. Information of all kinds is good. I mean, we're here talking about we want more and more, calling patients called pill consider. I did my body mass thing yesterday and discovered that my torso was under muscle. And this morning I changed my swimming routine. So, all these little things count, making people pay more attention to it. Long run, 23andMe and our competitors are all going to be moving, I assume, towards full sequencing as it gets cheaper. We outsource the actual. Right now it's simply detecting SNPs and long run sequencing. But what we really ask the party is, as you said, it's we search the literature, we personalize it for the person, and then we give them information, which by and large is not actionable, but it reminds you about the things that you already know you should do.
Yes.
Dr. Oz, I've heard a comment, I think you made on Oprah about energy medicine, and then maybe a comment on Dr. Ignaro's study with NO and its help for the heart.
Well, I'll just speak broadly to energy, and I'd love to have my colleagues' opinions. We really don't have the ability to measure energy as is perceived by Reiki masters and acupuncturists. And many of these therapies have been used for millennia in other countries, especially for chronic illnesses, with reported success, although, again, it's very difficult with our Western standards to demonstrate efficacy. It does seem to me that we define life at its very fundamental level as an energy, as a cell that's able to keep an energy differential between inside and outside, right? That's what an energy difference looks like from the perspective of a cellular biologist. And when you aggregate those cells together into an organ, you would think that there'd be something energetically important about the fact that cells are defined by their ability to keep energy on the inside different from energy on the outside. And in fact, there are some interesting research studies that have been done. There's a gentleman named Nordstrom, who was at the Karolinska Institute, who actually developed the fine needle biopsy technique. And many of the people don't know this, but when we want to biopsy to see if you have lung cancer, we put a little needle in there, and we can find it through a CT scan, and we take a little bit of cells out and say if it's cancer. Nordstrom invented that technique, and that's not why he invented it. He invented it because he thought by putting a needle into the tumor, he could see that the energy of the tumor was different from the energy of the regular lung, and diagnosed that it was cancer. But it turned out that there wasn't a lot of interest in finding out energies. They made the needle a little bit bigger so you can get some cells, and now we do the old-fashioned Western technique of looking at the cells. I think we leave a lot of opportunities on the table by not examining the role of energy in health, and particularly in the heart, which is our internal metronome, which is characterized externally by, obviously, electrical signal, which is the EKG, but also seems to be stimulating a lot of other things that happen in our body, especially if you're looking at things like heart rate variability that predict how our autopilot deals with the world outside of us. We have wonderful opportunities that we should be pursuing. And many of these molecular level changes that are occurring, for example, nitric oxide, influence of cardiac function as a neurotransmitter and other ways, may exert part of their effect by affecting energy in ways we don't understand. And I'll give you with one sort of titillating insight. There's an acupuncture point on the foot, an acupressure point as well, that's associated with eyesight. And it turns out that when you stimulate that part of the foot and you look at a functional MRI scan or a PET scan, you actually see the occipital lobes of the brain light up, which is like where eyesight is. But there's no connection between that part of the foot and that part of the brain by any known neurologic route or blood-borne route. So it violates our traditional Western understanding of how parts of the body connect. But it might be, in fact, that there are energy meridia, much more similar to how you would describe it in Eastern medicine, that may have some validity. We just don't know how to measure it yet. And that, I think, is a very exciting place for us to play.
He asked about nitric oxide, if I can answer that. So NO, nitric oxide, that's a gaseous substance, a gas made within the body by a series of enzymes. There are 3 different enzymes, but the one that's relevant in the cardiovascular system is the eNOS, or the endothelium making nitric oxide. That is believed to be an important molecule that mediates some of the action of the endothelium that I talk about as a protective issue. So I think your question is, what do we know about this? That most of the studies that's been done, and Betsy actually did some of the studies, early studies in that area as well, in human and in animal, would suggest that when you have a low amount of NO or it's inactivated, in fact, your endothelium is not doing as well, and you're more prone and susceptible to, say, inflammatory situation and disease in blood vessel. The following up is the idea of giving agents that can increase NO as a way to treat, and that's Dr. Ignaro's. In fact, as you know, he and Murad and Furchgott got Nobel Prize for discovering NO. This piece is a little bit more complicated because, there are no direct ways to create nitric oxide except you can give secondary agents that can make nitric oxide or stimulate the enzyme make nitric oxide. And there's a lot of circumstantial data suggests it will work. And one area which I was involved with is called L-arginine, which is a substrate that actually drive from eNOS to nitric oxide. And John Cook and I, when I was at Stanford, did a lot of study of L-arginine in animals and humans showing its beneficial effect. But there's been no clear study that look at heart attacks, stroke rates, etc. It's all suggestive evidence that you can relax the blood vessel better and it functions better. So I still say remains the category, like many categories that we're talking about, that suggestive but not proven. And I know people are, in fact, taking these agents, particularly as over-the-counter nutraceuticals, etc.
Yes.
Dr. Oz, thank you for scaring the living daylights out of me. I'm going to dodge my grandmother ate tulip bulbs and my uncle just passed away from a heart attack. And so it's going to be great for me to kind of scare the living daylights out of my parents to get them to really worry about their health.
Can I interrupt you for 1 second?
Yeah.
The part about this that I find most fascinating is that the epigenetic influence doesn't stop with the first offspring.
Now you scared him even
Yes,
more.
I know. But go ahead.
So you were all talking about the stiffening of the arteries and regeneration and master swim classes and ultra athletes like Christopher Berglund.
Yes.
They're definitely helping to prevent and regenerate. So how can I get my parents, this is my thought, how can I get my parents to be more active? And for our people,
Scare the living daylights out of them.
have you heard of a therapy called enhanced internal chemical pulsation? And what do you think about that?
Well, go ahead.
No, please.
Well, it's people call it by the EECP, which is the acronym. It's used quite commonly for people who have angina. It's actually FDA approved for heart failure. It's a bunch of blood pressure cuffs you put on your leg, and as they squeeze sequentially, they push more blood to the heart. And they actually, I think, increase nitric oxide levels, which Victor can discuss. But from a perspective of your parents, that's not where I'd go. Because what your parents need to do, number one, without any question, is walking. It's the one thing we know in every long study looking at longevity in humans is an effective tool, in part because it builds core strength.
Yeah.
It also ultimately is what aging is all about. Yeah. Because we don't die of cancer, really. I mean, if you got rid of all the cancer in the country, I mentioned last night, you increase life expectancy by less than 3 years. What kills us is frailty. And that's the main message that you have to get clear. And walking also, you don't get hurt usually doing it.
Just to reinforce that, and Ray, we promised that we wouldn't do the 10 Commandments of thou shalt not. But I couldn't.
How about the 10 suggestions?
The 10 suggestions, the David Letterman top 10 or something like that.
That's right.
I couldn't agree with Mehmet more. Walking is something easy and simple that just about everybody can do. And it's something that you can gauge to your own speed, to your own joint ability, your own fragility, whatever, distance, time, speed. But doing that on a consistent basis, I think, is one of the most positive things that any individual can do. The other piece that I like is that it can also be very social. You know, a number of women now have their walking groups, and which are a great way to get out and chit-chat and relax and social. And so I can't emphasize my concurrence in the importance of walking more.
Yes.
We talked a lot about aging heart and like the cell dysfunction. What about aging heart and
I'm sorry? What about?
Aging heart and electrical function.
Victor, take that
good.
picture.
Yeah.
Sure. Well, generally, there isn't much except that the degeneration of the conduction system and the fibrosis that Betsy talked about, degeneration, can occur and occurs in some patients, so they have heart block,
How about
AV block.
atrial fibrillation?
Right. And atrial fibrillation certainly increases with age, particularly with stiffening of the ventricle. That increases, in fact, the pressure in the atrium together with the fibrosis that you talked about. Yes.
There is, as Victor said, it's a scarring that can occur that leads to the heart block. You have this natural pacemaker, and that can stop, and then you need a pacemaker, or you can develop atrial fibrillation, which is the irregular rhythm, and that can be just part of the
He's a physician, by the
aging
way.
process. Yeah. Oh, I'm sorry. Yeah.
But a surgeon.
But you know,
Yeah.
no. But I'll tell you something that's very interesting. I spoke yesterday about comparative effectiveness research. The number one condition that the IOM said that we need the most research on of what procedure or what medicine works best is atrial fibrillation. Number 1 out of 100. And the question was, they were. Oh, I'm sorry, Judy. Quartile. All right. I understood at the top of the first quartile. Judy's with the Institute of Medicine.
Say it again, though. I didn't. So was it or was it not?
Everything was not, since it was, we didn't want people to have to differentiate between number 1 and number 2, which was better, which was more important. They were just lumping.
There's a group of them that's
Quartile.
highest.
There's a group.
So it's alphabetically, it was first in that quartile.
I don't know how.
All right. But nonetheless, the question is what works better, catheter ablation, of getting rid of the abnormal cells that lead to the atrial fibrillation, or medicines. And that's a study that the Heart, Lung, and Blood Institute is sponsoring right now.
Yes.
Question. We're talking about the heart as it ages. And it's particularly interesting to me because at 35, 36, actually, I was told that I had the heart of a 70-year-old. And so what should I be looking to do? Obviously, exercise is one of those things, but when I try to exercise vigorously, I gain the angina and am symptomatic. And so as my heart ages, when I reach 70, which I'm planning to, will it be 105? 150?
Yeah.
Or should I be looking forward to the regenerative powers that you all are talking about? And actually on my last scan, I was told that my heart had already begun to heal itself, but they were very surprised that it had begun to heal itself. And the vessel that would have been 100% included was now only 50% included, which was surprising. And
I mean, Rhonda, you don't mind people talking about your situation?
I don't.
Okay, so Rhonda's had a heart attack when she had her 4th pregnancy? Third pregnancy. And she had a left main and a number of other artery disease and had a huge infarct. But now it's actually the ejection fraction is going towards the contractile as with 45, just about coming towards the lower part of normal. To me, that's some evidence of repair and regeneration because you're a young person. And we have all seen this. I'm sure Mehmet's seen this. When young people have a heart attack, sometimes you go back to EKG and say, where is it? Especially inferior MI, right?
Yep.
And so I think the good news is that. But you're going to have to really work hard on your coronary arteries, which is, even though you may not have any obvious risk factor, you're just going to have to pretend as if you got them.
And so I medicate as if I do. I take all of the ACE inhibitor, the beta blocker, all of that. I take the protocol. My T waves are inverted on my EKG.
Right.
But what would the two of you recommend in terms of exercise for Rhonda?
My feeling is she needs to enter a rehab. I asked her yesterday, is she in a rehab program, you know? And you might have done it after a heart attack, but you ought to be on an ongoing rehab program that can monitor you to get the right level that you can tolerate.
You know, Ryan, if you're still having angina, my Dutch hypochondriac friend up front here, his recommendation of EECP, extracorporeal pulmonary pulsation, you'd actually be a pretty good candidate for it because your smaller arteries are intact. And we always talk a lot about, those of you who've had heart issues, you know, the big artery disease that we actually fix, the mechanical problems that especially men get, we're pretty good at that. But the small vessel stuff we don't do so well. And oftentimes you don't just get one, you get both. That's why women are so hard for us to treat, because they're more likely to have small vessel disease. But your small vessel disease is because you happen to get a dissection into a path. The infrastructure of the vessels is intact. And that's why EECP may, for you, actually be a pretty wise way to go. Yeah, you ought to try the ECP. I've had a lot of patients with pretty good results with that. It's time consuming, but it's worth it. It's worth it. Yeah. Yes. Now we have an expert.
Well, I've been measuring vascular aging on a little bit more than 100,000 people in 4 cities at very advanced coronary risk assessment centers, and I'm glad to hear all the different components. What we're seeing is that, first of all, there's a lot of good news here. We see people who are age 70 who have absolutely no evidence of plaque, at least calcified plaque by electron beam tomography, and they can't wait to tell their parents about it. Stiffness in patients, and that's the first thing that we're seeing before even diastolic dysfunction. We're looking at central aortic blood pressure, and that precedes seeing high blood pressure by a regular cuff. So we're also looking at this endothelial function using techniques. But some encouraging information. First of all, the endothelium is the size of 6 tennis courts. People know that, a 70-kilo man. You need to take care of it. So people like Bob Vogel at the University of Maryland have done some interesting experiments. You have a Big Mac. That's 6 hours of endothelial dysfunction after one Big Mac. You see a scary movie. You get endothelial dysfunction. You then, like Saving Private Ryan, you use for a very stressful movie. You see something funny or humor in your life. Endothelial function improves. What we're noticing is that there are a lot of people who have vascular age that's very high, but if they don't progress, that's old news. We can give them good news, is that if you've got the arteries of a 70-year-old when you're 45, but you don't get worse, your event rate is very, very low. No matter how high your score is, you have a score of 1,000. You have a score of 1,000 on ECT, and you progress more than 15% per year. 50% of those people will have an event in 2.5 years. Take the same group on Lipitor, score of 1,000, they don't progress, and after 6 years, only 3.5% of them have had an event. So it's the progression of disease which you're laying down all the time. So vascular stiffness is important. Vitamin D, we're seeing people with low vitamin D levels that do have much more atherosclerosis. So there's ways of measuring this, and there's a lot of good news because we're seeing older people with excellent endothelial function, even though they have a lot of plaque. When they go on fish oil and have a Mediterranean diet, they improve the available amount of nitric oxide to their cells. So there's a lot of news.
Yes.
Just to clarify on that, a Big Mac has 29 grams of fat. Any high-fat meal really above the 20%, or at least high-fat.
She does, yeah. She asked it earlier.
What did she say?
I have one question or comment that I haven't heard at all as far as preventive with any kind of disease, whether it be heart, diabetes, or what have you. But I'm a firm believer in massage, which I have on a weekly, sometimes several times a week, and I've done this for the past 10 years. And I'm not a doctor goer. I have nothing against you doctors. I haven't been to a doctor since my son was born, which is 24 years ago. I take 0 pills, nothing. And I think the massage, that stimulation of the blood and the flow, you feel terrific when you get off the table. So 90 minutes, several times a week,
So it's worthy of commenting because Mehmet knows that, we have a integrated medicine center at Duke. And in fact, we do all of the massage therapy, acupuncture, you name it. But the important thing is to get the evidence from a more prospective way that's really making a difference. So your individual experience is important, but I think really it's getting evidence. And the other thing is making it available to everybody because, as you know, you have to pay for this. And this is the healthcare reform discussion, right? And so I think those are the kind of things we need to make sure that we move. I think mind, brain, behavior, many others have a lot of validity, but it really should enter into evidence-based treatment.
I think the other comment, I agree firmly with Victor. We do need to collect information and gather the evidence. But I think it's been probably all three of our observation that each of us as individuals know what type of behaviors lead us to be relaxed, reduce the stress, promote a balanced lifestyle. And we all know that in our own way promotes health. So for you, it's massage. For someone else, it might be walking. I mean, we all have stories and examples of that. So if you're feeling healthy, carry on.
But see a doctor every so often.
We don't want to go out of business.
Just a checkup.
Exactly.
You answer it.
Yeah. So yes, the technique that he describes, brachial artery reactivity, is a very standard research methodology. We support many research studies that use this technique to measure endothelial cell function. So it's been very well standardized. I can't comment on whether it's used in a clinical setting. I think it probably.
You say it's reimbursed?
But often, but probably not consistently. Yeah.
So I think if you look at the data collected to date on endothelial function, it's not an easy method to use. It's not like getting a blood test. It correlates quite well with the cardiovascular risk and correlates quite well with other risk factors. So it is a good predictor. And the argument would be that you can reverse it would be better. But it's still generally considered as, experimental, but have a lot of data supporting it. So it's nice to hear. I mean, I think you can use it to guide you to think about how things are going, but it's not definitive. It's nice to hear that, in fact, people may reimburse for this.
I'd much rather you get a functional study like that than many of the other scans that now are being reported. For example, if you're going to get a CT angiogram, which gives you very pretty pictures of the heart, there's significant exposure to radiation, and we don't often know what to do with the information. Mm-hmm. But if you have a test that tells us that your blood vessels aren't reacting correctly, that's one of the first ways we can tell if you have signs of atherosclerosis. And frankly, once you know you have signs of atherosclerosis, you ought to take proactive steps accordingly, whether or not you've got a 30% plaque or 40% plaque in your arteries. So I like the idea of a non-invasive study that gives you information that you can guide therapy on. And everybody in the room is important. Functional studies are more important to us than anatomic studies. So specifically, if you have a map that shows you how to get to Manhattan and you can go across the George Washington Bridge, the Holland Tunnel, Lincoln Tunnel, Many of you realize it doesn't matter if those exist because if they're always backed up with traffic, who cares? Right? So you want to know what the traffic patterns are as much as you want to know about the anatomy.
Thank you, Doctors Oz, Nabel, and Zhao. Thank you for your very good questions.